throat cleared. Okay. Good morning, everybody. This is Joe Hyde, and I am here to introduce to you Michael Botticelli, former state agency director from Massachusetts and former project director for the Massachusetts SBIRT project, who will be talking with you about lessons learned from SBIRT in Massachusetts. With that, I think I will turn the mic over to Michael. And if you have questions, please put them into the chat function up in your upper right-hand corner, and we will take all questions at the conclusion of the webinar about 45 minutes from now. Thank you so much, and Michael?
Great. Well, good morning, everybody. It's really nice to be here today. It's actually nice to be here on a much better weather day, and I hope, particularly for our colleagues on the East Coast, that you're all doing well and you and your family are safe. Want to thank JBS for the invitation to do this. It's really fun to think back over 5 years in terms of kind of what's worked with this project. So why don't we head into this as we go forward. Great. So one of the things that Massachusetts did in 2005 is that we went through a very long and very exhaustive strategic planning process, which I think is important not just for SBIRT grant, but for any grant as well, because I think it really speaks to how does this federal grant fit into your priorities as an administration. And I also think it was very helpful for us that as we did this strategic plan, we also did a financial mapping of where the state was spending its resources relative to substance use disorders. And what was very clear is that the vast majority of funding, both state, block grant, and even Medicaid funding, was spent on acute treatment services. And I think if you look at it in that context, it was very, very clear that Massachusetts, and I would assume that most states, are spending the bulk of their money really on high-end, very expensive treatment and not using resources to really think about how do we diminish those costs over time. And so it was very clear that screening and brief intervention fit in to our longer-term goals relative to what we were doing. And I think that really helped from the starting point building consensus around screening and brief intervention. Fortuitously enough, in 2006, Massachusetts was awarded a 5-year cooperative agreement grant through SAMHSA. It was a true partnership with Boston Medical Center, which is a very large urban multicultural medical center in the greater Boston area, and was implementing SBIRT in a wide variety of inpatient, outpatient, urgent care, and emergency departments. Massachusetts and Boston Medical Center had already been working on screening and brief intervention, so this was a very logical step. And quite honestly, I think really helped us relative to thinking about wider implementation strategies. They had 5 affiliated community health centers with Boston Medical Center, and we used, as many SBIRT grantees are, health promotion advocates in various settings. So this was usually, most time, paraprofessionals and peer-based, and implementing and inserting them into a wide variety of healthcare arenas. Boston Medical Center had a linked electronic medical record system already in place, so there was a fair amount of both programmatic and technological infrastructure in place that really helped with some of the rapid implementation challenges that we had to face. During the course of the project, we also added 2 other medical centers during the grant to make sure that we were meeting our numbers. And so you'll see, over the course of the grant, over 173,000 screens were done, representing over 132,000 unique patients, which is, I think, pretty good accomplishment. And again, keeping with strategic priorities, we also had 2 state-funded screening and brief intervention projects. One, I think many of you are familiar with Project SSIRT, which was developed by Ed and Judith Bernstein, and we were implementing that in 6 emergency departments across the state. Very clearly, emergency departments that we've heard, and I'm sure across the country, often feel burdened by the level of substance use disorders within their emergency departments. And I think this really presented a really good strategy to help emergency departments deal with the level of patients with substance use disorders coming into the department. We also, at the time, we thought we were doing a great thing by blending funding with the maternal and child health block grant for screening of adolescents and women of childbearing years within community health centers. And I put that this project was ultimately discontinued as opposed to the project miserably failed. And I think that we actually learned more from our failures with that project in terms of how not to manage a project versus the federally funded SBIRT project, which I think was ultimately a success, and I'll talk about that through the presentation. So just to give folks a little kind of context in Massachusetts, Massachusetts has historically high rates of alcohol use versus the rest of the nation, both in terms of underage use, binge drinking, and adult use. So clearly, we have a public health issue relative to alcohol use. This also happened, and I think there are pluses and minuses to this during the implementation of healthcare reform in Massachusetts, which leads to the next bullet, which is, dramatically increasing healthcare costs. So what Massachusetts did for healthcare reform is expanded coverage and is now looking at containing healthcare costs. So we had both increasing Medicaid costs in and of itself, but largely as a function to the expansion of healthcare reform for a Medicaid population. So really high, even exacerbated healthcare costs as opposed to just in general. There was also a decreased appetite for insurance mandates. So I think if Massachusetts was going through healthcare reform, that there was not an appetite within the legislature or with anyone else to say, here's one more thing that insurance companies have to do, particularly if it had any sort of increased cost attached to it. Clearly, as everybody, I think, had experienced, just a severe economic downturn, declining state revenues, unfortunately not substance use disorder budgets, but just shrinking budgets overall. So here you have this kind of juxtaposition of increasing healthcare costs and at the time really shrinking state budgets. So I want to talk a little bit about what I see as kind of overall accomplishments, and I think this is general not just to Massachusetts, but what we've seen nationally relative to SBIRT projects. But I think it significantly raised the awareness in both medical and substance use disorder sectors of unhealthy use. And I think many of us who are in this field, are used to some of the terminology that we've experienced, that basically you had to wait till people hit bottom before, there was any sort of treatment protocol, or that was the intervention point or the opportunity for intervention. And the teachable moment was when someone had to basically self-diagnose. I often say that substance use disorders, before SBIRT, was the only disease where people had to kind of diagnose themselves before we decided that we were going to give them any sort of intervention. So I think this really helped, again, in both fields to say, well, wait a second here. We do not, like many chronic diseases, we do not have to wait till people get to their most acute, where it's the most expensive and most difficult to treat, to do. Screening and brief intervention as a bridge between primary care and behavioral health, that this was clearly something that could be implemented in multiple settings, and not just primary care, but particularly primary care. This is not necessarily something that needed to happen within a specialty care treatment, but really was positioned as part of primary care. And I think that part of it was, it's analogous to what we do with many, many other health conditions. So with tobacco and with weight and with blood pressure, we do screening and brief intervention on a periodic basis and a systemic basis in primary care settings. And I think what we were saying is, here's one more issue that we think is important to do. And growing awareness of screening and brief intervention as essential to overall health. And I would say that it's beyond just screening and brief intervention, but a growing acknowledgement both nationally and within Massachusetts that we couldn't treat behavioral health issues and separate from primary care. And I think, as many of you know, we're primary care, integration with primary care is the main focus of how we see getting more people into care. But I think there's a growing acknowledgement that we can't ignore behavioral health issues if we want to get good outcomes on the medical side as well. The integration of health promotion advocates as part of healthcare teams, I think, has been important. And again, I think this parallels work that's happening with community health workers, happening within the mental health field in terms of the role that peers have within healthcare teams. And I think that we've seen that these are kind of well-trained, kind of well-supervised health promotion advocates can really function and be a part of a healthcare team. It also created innovative IT models relative to one of the things that we worked on was telephonic screening. So how might we not think that some of this work just has to happen on a face-to-face basis, but can really happen using some of the more innovative technologies that we have in front of us. It greatly expanded the state's continuum of care. As I said before, we, and I assume that most states were, spending the vast majority of their dollars way upstream on acute treatment costs. So it really helped us to think about expanding that continuum of care. And again, really changed the conversation on how we approach substance use disorders. And that maybe should be the kind of major takeaway, at least I think for us, is that both, but particularly within the medical community, I think it really, again, focused on the fact that we do not have to wait till people reach their absolute most acute condition before we decide and before we know that there are things that we can do to intervene and either prevent people and prevent folks from reaching the acute phase of their disease. One of the important parts of the grant was really thinking about kind of a policy steering committee. So who at the state level should be involved in not only the implementation of the grant, but also helping to deal with some of the larger policy and systemic issues as they came to the surface, but also thinking about sustainability and systemic change. So I think there's lots of opportunities here for involving many constituents and many stakeholders in the policy steering committee. So clearly the governor's office, which the grant requires, the grant actually goes through the governor's office, can really help, I think, navigate through some of the interagency and cross-agency issues that come up with the grant, as well as thinking about broader sustainability goals. Clearly, Medicaid has a big function, and in many states, the behavioral health services are carved out. So involving the behavioral health managed care organizations can really be important when you think about sustainability or broad systems change. The Insurance Commission, who has responsibility for thinking about and setting up the benefit plans and looking at the benefit plans in most states, I think can really be helpful in terms of, again, not just policy administration or grant administration, but thinking about long-term sustainable goals. Clearly legislative leaders is important. In Massachusetts, we had a mental health and substance abuse committee within our legislature. So involving them in the committee, I think, is really important, both in terms of helping them see that there are other interventions, but also kind of what's the potential here for cost savings as it relates to substance use disorders. Involving community-based organizations is important, as well as recovery community organizations. So I think, SBIRT is an opportunity to kind of bring people along and getting those folks to the table and being part of the table, both to help with implementation and to help champion your successes, I think is really important. Involving your primary care office. So primary care offices in many states are within the state's health department, but also work significantly with federally qualified health centers throughout the state, and I think can really be good champions and help to develop them championing SBIRT both within community health centers and in other parts of the healthcare arena. Looking at the primary care and substance use disorder provider groups, I think is also helpful in terms of the administration, implementation, and long-term sustainability. And clearly the medical society, I think, or medical groups within your state can be real champions and advocates when we're talking about the integration of substance use disorder and SBIRT services within primary care. So, and I spoke to some of these issues previously, but, clearly utilizing the governor's office, they can be really helpful. I think if if someone calls you and from your state's governor's office relative to thinking about or asking for a meeting to talk about screening and brief intervention is really helpful. It can help build relationships with new players. I think both in terms of healthcare reform and some of the other changes that we're seeing with the composition and delivery of health and payment reform with healthcare, that they really can help establish relationships with folks like the Insurance Commission that historically state substance abuse agencies haven't had working relationships with. I think to understand and use the perspective of your members is important. So each player in this might have different questions, different thoughts, different ideas about what it takes to implement this kind of system change and policy changes, as well as thinking about sustainability. So I think that they can really help you to understand kind of what might be significant challenges relative to how does screening and brief intervention fit into a specific clinical arena, or how does this how might this affect payment and cost savings. So I think having a well-rounded group of stakeholders on the policy steering committee can really help inform and aid implementation challenges before they arrive. Excuse me. Leveraging their perspective to help build the business case can open doors. So if you already have those relationships as part of your policy steering committee, you can continue to leverage those relationships and keep building on them. And again, it can also help identify existing and future opportunities. There is so much happening within the healthcare delivery and payment reform system that those players can help you identify what other things might be going on in your state and how you might be able to weave screening and brief intervention as part of that. And we'll talk a little bit about those later on. So from a project management, and some folks might have different issues, but we found it helpful to involve our legal and our IT departments right from the start to make sure that we were not implementing programs, we were not executing memoranda of understanding in ways that didn't cut legal muster, or that our IT department was not jumping up and down because we were building something that was completely outside of the domain of state services. I think that there are other states might think about when they involve their legal and IT departments, but it's always a good idea, at least we found, to invite them in from the start. That is actually something that we did not do with our project, and we paid the price later on relative to all of the work that we do. I think we finally executed a data use agreement with Boston Medical Center, I think 6 months before the grant ended. So I think it's our lesson that if we had to do it over again, we would do it a little bit differently. Flexibility is the key, I think, as you're looking at how you involve new sites, how you look at hitting your targets. So, the best laid plans, I think, of either folks who write the grant or when you start the grant, you think you're going to hit your numbers and you find out very quickly that you might not meet your numbers. So having to really reevaluate kind of your sites and where you're going to implement and how you're going to implement, I think is important. So, flexibility and maybe, a lot of patience, I think is really helpful. Also, think sustainability right from the start. One of the issues, one of the good things that we see with federal grants is that they're relatively resource rich in terms of the models that people are implementing, and those might not necessarily be the models that we think are ultimately sustainable. Or, the development of IT systems that are generated for GIPRA reporting might be different from what you think from a clinical record. So thinking about, what is this project going to look like, or what do you want to have happen at the end of your grant period? I think trying to have those conversations and thinking about that from the beginning is important. And but I also acknowledge the challenges of that, because I think I think all of you know that Grants often require a very rapid startup period. That implementation can be challenging, and so kind of balancing, okay, I've got to, see my first patient within 3 months, and thinking about sustainability might be hard. But I think the sooner you can have those conversations during the grant process, I think the better off you'll be. Build the business case for insurers, employers, and other key policymakers. And again, I think this is where having multiple perspectives on your policy steering committee can help you figure out what is the business case I need to make with each of those different folks, either from a clinical standpoint or from a business perspective, to think about widespread system change and widespread implementation. Market your successes, so be an unabashed champion for what happens. So think about things like newsletters or presentations to your primary care society or presentations to your medical societies. I think that many of us kind of see the tremendous success of our grant processes and grant projects, but unless we tell people about them, it really is not going to help kind of grease the skids to more systems change. And ask for technical assistance. And no, JBS did not ask me to put that bullet in the slide. I think that what we found is that the faster and more transparent you can be about the challenges that you're having with your grant and asking for technical assistance, I think the better off you are. I think we, all have done technical assistance over the years. It's not a system that is set up to point out where you're going wrong, and it's not a gotcha game from a technical assistance standpoint. But so I think that the worst thing people can do is wait until problems get exacerbated before they ask for technical assistance. And I will also say we're far along enough in the SBIRT process that that there is a tremendous amount of expertise both here at JBS and with other SBIRT cohorts that I would assume that your problems are not novel, and there are other states or other jurisdictions who have implemented them well. So just want to talk a little bit about site selection. I know that many of you looked at in terms of the grants, but also thinking about continuing to meet your numbers and what sites you need. Clearly finding a champion and the higher level champion within whatever the organization or whatever the arena is, I think is important. You really need someone kind of high up in the management to champion this project, because there's going to be issues and problems that are going to come up. And I think having someone who's willing to kind of continue to work through those issues is really going to be important. We found that recruiting sites individually rather than a scattershot approach was particularly helpful. So, early on in the grant, we invited everybody to these meetings, and then, we were surprised that no one followed up with us in terms of wanting to take it on, and really had to, again, I think, rethink that approach and really had to look at recruiting sites individually. So doing some, more direct marketing, doing some target marketing to sites was better than just doing, a spam email, if you will, to do that. Maybe this, should be the first bullet, but do not underestimate the culture change, both within the healthcare and substance use disorder field. And I think that, I've seen that, and many of us have seen that, whether it's screening, brief intervention, or implementing other integrated care practices within the primary care field. I think there is a broad feeling that clients in primary care settings do not have substance use disorder issues, that all of those folks should be served through a specialty treatment system, and in some respects are untreatable. And so I think that we have to bring people along and do education along the way. So don't underestimate, I think, the culture change that needs to happen within the primary care field, because I think that can really sink projects right out of the starting gate. And, if I go back to kind of one of the, failures that we had with our community health centers from our other SBIRT projects was, in essence, that this was kind of a grant-imposed requirement. And there wasn't a lot of conversation and education early on with our community health centers. And I think what we found is that it was harder to pick up the pieces versus starting out the conversation at a much different place. I think there was a lot of work, not only at the beginning of the project, but throughout the duration to really focus on unhealthy use versus high-end treatment. I think many sites felt like they were going to, once they started doing screening, that they were going to, the vast majority of cases that they were going to uncover were going to be people at the higher end of the addiction framework, i.e. those folks that actually did need treatment within specialty settings. And I think continually reframing that, whether through numbers and data, to show that no, we're really talking about and focusing on folks who have unhealthy use versus those that have addiction or and/or dependency and need high-end treatment. So it's kind of, I think there needs to be this constant reframing about, particularly who the target population here is and what their needs are. Because I think, particularly health professionals who are not trained in addiction feel like that they are not equipped to deal necessarily with those folks who have high-end addiction issues versus those that have unhealthy use. And I think if you can continually reframe it, that as health professionals, they do this all the time with other disease and other behavioral issues. So whether it's smoking or exercise and diet, they're continually having those conversations and have skills that are transferable to screening and brief intervention. Clearly the IT infrastructure to support the efforts and data requirements can be challenging. I think, we all know the benefits of GIPRA, but also GIPRA reporting can be very challenging, and particularly for sites that might not have robust IT infrastructures to be able to do that. Sometimes particular sites don't control their IT and their electronic health records, so convincing folks at the corporate level to make alterations to their IT infrastructure can be challenging. So I think it's important to think about ways that you can support that. Clearly finding sites with high patient volume is important. So, you've got numbers to hit. And I think making sure that you're spending your efforts in those practice arenas that are going to give you the patient volume that you need is going to be important. As well as getting to know, and I think this is why it's helpful to look at sites individually, is understand the patient workflow in each of the different areas, because it's going to be different from practice site to practice site. And particularly when you're thinking about how does a health professional work within that flow, I think is really going to be important. So spending some time helping folks or asking folks to diagram their patient workflow, I think is going to be really important in terms of how folks get inserted into this. And so clearly workflow is a part of the thing that you have to work through. Fidelity, I think, is a continuing issue. I think many of you know with the implementation of any evidence-based practice that keeping folks, so not just an initial training, but how do you make sure that folks have adequate supervision and adequate ongoing training to make sure that they're implementing screening, brief intervention, and brief treatment according to established protocol. Again, keeping the focus on healthy use, so making sure that we're continuing to focus on identifying folks who have unhealthy use and who are needing brief intervention within primary care settings, I think is particularly important. Referrals to treatment provided both an opportunity and a challenge. I think the opportunities is that primary care practices started developing working relationships with a number of behavioral health providers that they hadn't necessarily worked with before. And so I think that it really forged some more strategic alliances. Unfortunately, the challenge in Massachusetts and I think in other areas is we all know that, kind of getting into treatment can take time, can often be cumbersome, can be wrapped up in insurance authorization issues, and that can be a significant challenge for a very busy practice that often doesn't have the time to do the things that they're already doing, let alone, thinking about additional referrals, and particularly when they are very, very time sensitive. As we said, data requirements can be challenging, so how you might be of assistance or working with folks to make sure that they're looking at both submitting DIPRA and doing up the follow-up requirements that are part of the grant. As well as data sharing, I think can be particularly challenging. So we're often talking about information that can be part of people's electronic health records. So what information gets shared with whom, when, I think is really important. And it's also, I think, speaks to involving your legal department and particularly your privacy office so that you understand what the confidentiality issues are with some of the data sharing work. Building the business case for screening and brief intervention. We in the public health world are I think, tremendously mission-driven. We're really great at kind of the helping piece of this. But we're also talking about how do we make sure that we build the business case in ways that some of our stakeholders can understand and can think about implementing system-wide. So particularly using data to show cost of untreated substance use disorders, I think is important. And I didn't do a resource list as part of this, but there's a tremendous amount of resource, both from SBIRT grantees, but also national data that show the cost of untreated addiction. I think that can really help open doors to say, well, wait a second here. Your costs are, for some of your folks with chronic conditions are exacerbated by untreated substance use disorders. As we talked about, financial mapping of behavioral health expenditures can be helpful. I think if you can demonstrate as a state that the vast majority of your dollars are going to high-end acute treatment, it does, I think, in a very visual and a very stark way, show that, well, geez, maybe we start needing to either redeploy or augment resources farther upstream where we can do interventions, less costly interventions over time. And again, I think the more that you can draw parallels from other diseases, I think is really important. That, it doesn't make sense for us to not think about screening and brief intervention for substance use disorders in the same way that it wouldn't make sense for us to not do blood pressure screening or blood glucose tests for those folks who are at risk for diabetes. Use other SBIRT grantee resources. So and I'm sure JBS has a fair amount of documentation from other states, both in terms of clinical outcomes and return on investment strategies. So there's lots of opportunity among the grantees to share those resources. And use established standard of care documents that talk about screening and brief intervention as either a validated or a soon-to-be validated measure, or as best practice. So there's the National Quality Forum that has put screening and brief intervention as one of their evidence-based practices. The Joint Commission is now looking at, I think, on the verge of accepting screening and brief intervention as a measure, and clearly HEDIS measures that private insurance have to look at, I think are all incorporate screening and brief intervention. So I think the more that we can say this is a developed standard of care as part of medical practice, I think it can really help you make the case. So relative to sustainability, again, there's much happening at the state and the national level relative to how we might build in measures into state contracting standards. So clearly Medicaid is and will play a larger and larger role, cover more and more people. So how we think about and what's your opportunity to work with your Medicaid office to think about implementing screening and brief intervention as part of the contractual standards that they have to comply with can be helpful. EPSCT, which stands for Early Periodic Screening, Treatment, and Diagnosis. I think it's the other way around. It's DT, not TD. It's Diagnosis and Treatment. But which is a Medicaid-run program that requires Medicaid recipients under 20 years of age to get both medical and mental health screenings. And in Massachusetts, we actually worked with Medicaid and EPSDT to have screening and brief intervention as part of their reimbursed protocols. So there's a good opportunity. and many health departments contract with school-based health centers, which are federally funded. So again, it's another opportunity to implement screening and brief intervention and referral to treatment as part of the contractual standards for those folks. Some grantees, SBIRT grantees, have done screening and brief interventions throughout their HIV/AIDS service contracts, which has been really effective since we all know the significant levels of drug use with folks at risk for and with HIV and AIDS. Much work is happening now with patient-centered medical homes, and again, it's a great opportunity to think about incorporating not only behavioral health in general, but screening and brief intervention for those patient-centered medical homes that are now being developed. Clearly, many states are looking at the implementation of accountable care organizations, and accountable care organizations are a network of contracting providers who are both financially responsible, who are both clinically and financially responsible for a group of patients, and making sure that behavioral health is part of the network of providers, and thinking about screening and brief intervention can be really helpful. So if you can demonstrate that screening and brief intervention or referral to treatment will actually reduce costs over time, that it can be a real selling point for that service within the development of accountable care organizations. Many states have or are in the process of looking at projects for clients who are dual eligible. And dual eligible are those clients who are both eligible for Medicaid and eligible for Medicare. I think CMS understood that dual eligibles are some of the most costly and hard to treat folks that we have at the state level. And at least data in Massachusetts, and I would assume that this plays out nationally, showed that many of those clients had untreated mental health and substance use disorders. So how we do screening and brief intervention, I think, can really help if we're looking at how do we decrease the cost and get better clinical outcomes for folks who are dual eligible. So just a little bit more about sustainability. So what's really the role of the state substance use agency and the grantee here? I think what are the main functions? So clearly training and technical assistance I think is important. We want folks to make sure that they are implementing screening protocols and brief intervention protocols and referral to treatment protocols in ways that we know to be effective and proven. So there are, I think we all know that there are better ways to and better questions and proven questions to ask that will elicit the responses that we want, as opposed to kind of just leaving it up to the clinician on a ad hoc basis to figure out how to do this. Billing can be really cumbersome, so I think helping folks understand what the codes are, how to bill for those codes, I think can be really helpful for a state to think about how you do that. I think what we found nationally is that even states that have turned on the Medicaid codes and have allowed billing for screening and brief intervention, that uptake was initially slow, and I think that that's where it's really helpful to think for states to think about training and technical assistance to make sure that we're doing this in good ways, but that it's becoming part of practice, but also how helping them figure out how to bill for it, I think, is important. Again, I think fidelity is important, making sure that we're providing kind of ongoing training, ongoing opportunities to make sure that we're implementing this in ways that we know to be effective, as well as championing. I think that you can't underestimate the role that state stakeholders play in really championing screening brief intervention throughout the both medical system as well as the broader healthcare and human service system. So I think training is and championing is I think key to making sure that screening and brief intervention becomes a part of normal and routine primary care services. So that's all the prepared remarks that I have at this point, and I think at this point we're going to open it up for questions. So again, I think if folks want to submit a question via the chat box, they can do that. And we're, I think, going to open the lines here, or are we just going to do it through the chat box? I'm sorry, I forgot my instructions.
What do you think?
Chat box.
Okay.
Okay.
Yeah, we'll do it.
Given the numbers of folks that we have on the call, so we're just going to do questions through the chat box. So folks want to submit questions then. First question was, can we get these slides? Will they be sent to participants? And I assume that we can do that. Joe's nodding his head yes. So we can make sure that you guys get the slides for this.
While folks are busily typing into the chat box, I have a question for you. As a grant administrator, and you have contracted with a particular site who, for whatever their reasons, and sometimes the reasons may even be out of their control, it's just not working. How do you negotiate that relationship, or how have you negotiated that relationship so that it was both you got your needs met in terms of what you had to do and either moved on or whatever?
One of the challenging pieces of this is as Joe indicated, is when you're working with a site that's just not implementing in ways that you had anticipated. And I think part of it is that you want to sustain some of these relationships over time. So clearly, I think first and foremost, thinking about kind of approaching this from a technical assistance standpoint. So how might we provide resources that we either have in the state or federally to help think about doing this? So I think, one, thinking about how do we improve this as a first attempt, I think is important. But I think second, just kind of reminding our partners in this that we have federal obligations relative to meeting the numbers, I think is important. So, I think if you approach it first and foremost from a, technical assistance standpoint, what can we do here to kind of improve, make sure that we're getting better numbers, I think is important. And clearly having that conversation to say that, as the project director, I am ultimately responsible for the promises that we made, to hit those numbers and just have kind of candid and honest conversations with folks, I think is the best way to do it. So this is from, one of the questions was, are there Massachusetts resources on how to build the business case for insurers, employers, and healthcare providers? And I think the short answer is no. But I do think that there are other states, and I'm looking at Joe here, that have done some good work around building a return on investment case. And so I think that, they'll be happy to provide resources or point you in the right direction for other folks who might have done a good job in terms of building the business case. I know that one of the things, and I'll be happy to provide some models, but one of the things that we have a return on investment fact sheet that we did around tobacco cessation and including a tobacco cessation that I can provide folks, because I think it'd be a good template from how to do a very simple but well done return on investment case for inclusion of a benefit.
Yeah, and there have been from the first and second cohort, several grantees have published in journal articles. The state of Washington did, Wisconsin did, on looking at return on investment cost savings.
Great.
And certainly we can make those available, those citations available for folks to look at. Great.
What happened to the initiative with adolescents and women of childbearing years? So this is, I think, again, a good kind of lesson learned in kind of how not to do things. So part of what I think happened in this case is that we didn't have upfront conversations with the providers in this situation about what was going to be the strategic direction of these grants. And even though it was included as part of the application process, I don't think a lot of time had been built up front about changing the direction of these grants or even adding kind of a new initiative to this. Clearly, really the data reporting requirements were something that many of these grantees balked at. So this was a change from funding community health centers that just got basically infrastructure support to really having to be responsible for, a specific clinical protocol was different from them, and it wasn't a contracting standard that they were used to. So I think that we didn't do enough upfront work and upfront relationship building to do that. I think the second thing is, again, that one of the things that we heard was all of a sudden, I think community health centers felt like they were going to be flooded with all of these new people with addiction, rather than this was, an issue that many of their current patients were facing. And thinking about the fact that the vast majority of people that they were going to find had high-end addiction that needed referral to treatment. So we didn't do enough education, relationship building up to the time that we changed the contracting standards. I think the other piece, too, is that different from our federally funded SBIRT projects, we did not fund health promotion advocates within these community health centers, that we expected it to be part of their current practice. I think nurses felt, particularly nurses in these situations, felt like they were being overburdened with another grant requirement. So there were a wide variety of factors, but I think it really speaks to, the importance of relationship building. I think the importance of education for folks and bringing them along, both from a cultural standpoint and also kind of making the case of why screening and brief intervention is really important for their current patient population. We just didn't spend enough time up front making the case for it. Do you have any data or resources that would be helpful for making the business case for SBIRT screenings for mental health, depression, and co-occurring disorders? I think there's been a fair amount done relative to screening for depression. So I would assume that if you just did a relative search around depression. So actually screening for depression is already a validated measure. Yeah. So there should be so I think if you do a little bit of searching, you should find significant resources that look at screening for depression as a good practice that has return on investment. Has Massachusetts been successful in building SBIRT into the state contracting requirements for health insurance and other, just want to skim down, and other healthcare service providers? So again, I think that we have been moderately successful, particularly with a number of things that were going on. So looking at children's mental health and EPSDT was a contractual requirement that we were able to do. Just as I was leaving Massachusetts, they were looking at both processes for dual eligibles, as well as Massachusetts was re-procuring and just awarded its main carve-out for behavioral health services that looked at integration and looked at screening and brief intervention. So I think we were more impactful on the public purchasing side, Medicaid and its carve-out, than we were on the private health insurance side. What is the percent of brief interventions and brief treatment and referrals to treatment in Massachusetts? Unfortunately, I don't have that data in front of me, and I know I saw it just recently. But we'll be happy to get that to you. And I think our data probably holds true nationally as well, looking at the percentages of folks who screened positive, needed a brief intervention, those that needed brief treatment, and those that needed a referral to treatment. But clearly only a very small percentage, and I'm looking at Joe, I want to say only about 2 to 3%, depending on the arena, needed referral to treatment.
Yeah, I might have the numbers flipped, but referral to treatment, I believe, was at about 2.5% of the total cohort screened, and referrals for brief treatment was about the same, maybe a little bit more, like 2.7%. It's somewhere in there. And that held pretty consistently true across all 4 cohorts of grantees. So total of about 4.5% or between 4.5% and 5% of the total cohort of people screened ended up with some kind of a treatment intervention.
And again, I think that can be really helpful data when you're looking at sites and when you're talking to sites, because again, I think my experience was that many sites felt like that number was going to get flip-flopped, like that the vast majority of people and the vast majority of cases that they were going to uncover needed either brief treatment or referral to treatment. And I think showing them data from, particularly, a vast, I'm not sure what we're up to nationally in terms of numbers, but millions of people have been screened, that you're only going to, that only a very small percentage of those of that cohort is going to need brief treatment or a referral to treatment. So can you talk about what you included in your contracts with clinics? Was the training and technical assistance separately provided outside of actual contracts, or how did the contracting work? One of the things, again, I think that's important with any kind of, when you're looking at embedding those standards in any contract, and this is why I think it's important that simultaneously you have to provide the training and technical assistance to go along with it. I think that if you're implementing those contractual standards into any arena, that you have to simultaneously offer training and technical assistance to do it. And the exact language really looked at, I think, the percent of patients looking at some level of universal screening among of any patient population, and looking at a percentage of those clients who were screened positive, making sure they got a brief intervention or a brief treatment or referral to treatment. But I think that offering training and technical assistance by an outside entity, I think, can be really important in terms of a greater appetite for looking at screening and brief intervention. Oh, did I skip it? Yeah.
Has there been any specialized focus on older adults?
Has there been a specialized focus on older adults? We actually, not necessarily through our federal project, but one of the things that we had done with our geriatric service community was looking at screening and brief intervention. So I think it's really important, and I think, focusing on older adults, particularly the aging baby boom generation, as they reach older adulthood status, if you will, is, I think, really important. So working with geriatric providers, working with elder health caregivers, I think, can be really important in focusing on older adults. Oh, did I skip one?
We'll just double check and make sure we didn't forget somebody. From people here in the room, does anybody have a question?
How is this working? How is this working in mental health outpatient clinic?
Yeah, so there's a question here. How is this working in mental health outpatient clinics? And, in Massachusetts, I don't think there was a particular focus in terms of mental health outpatient clinics. I'm looking at Joe to see if he has any kind of national experience relative to other grantees.
A number of states have embedded it within their mental health clinics. I'm thinking particularly of Colorado. I know has done that, and with good success. I mean, it really is raising the level of screening for what's often a serious and persisting mentally ill population. And we know that there is a percentage of them with substance use disorders, but also some who perhaps are drinking at a riskier level, and given the medications they're often taking, that's not a safe thing to be doing. So I believe the Colorado's what that first comes to mind. I believe several other states have, but I'm more familiar with Colorado's information because of more recent experiences with them.
Do you have a training curriculum for adolescent SBIRT provisions? Actually, we do, and we did develop as part of the rolling out of screening for EPSDT, we actually developed in conjunction with Dr. John Knight and Sharon Levy at Children's Hospital, as well as with our one of our Medicaid behavioral health providers. We actually did develop a training curricula and a screening algorithm using the craft. I believe, I know that we can make a link to it here, but I believe that that is still on the website in Massachusetts, and that address is www.mass.gov/BSAS, B-S-A-S. And I'm pretty sure that that curriculum has been on our website. And actually that algorithm was adopted for use with the American Academy of Pediatrics. So that is free to download and for adaptation. How are you planning to financially support the health promotion advocates after the grant is finished? And the answer is we are not. So, clearly this is one of the issues, around sustainability that I was referring to before, that often what the models that we build for services, unless there are secondary payment mechanisms to be able to pay for the health promotion advocates, we're not able to sustain them. What we did after the grant was kind of refashioned our grant into a training and technical institute. So that was what the state was able to support. I know some of the sites anecdotally kept the health promotion advocates on board, figured out a way to pay for them, or found that there was value in having someone there to do that. So I think it varied by site, but we did not have the state resources after the federal grant ran out to support the health promotion advocates. Have any SBIRT projects focused on providing screening brief intervention in jail settings? And Joe Hyde, who's the master of all federal things, SBIRT, is shaking his head no.
There are some pilots going on in probation and parole, but not within specific jail settings.
Great. So again, I think a nice opportunity to think about, looking at pilot programs and looking at how you implement screening brief intervention with a criminal justice population, I think might be an area that's open for investigation. Do you have any knowledge of upcoming SBIRT grant opportunities? I think that the cycle, there was some new awardees, but I don't know if the next...
That wouldn't be until after the first of the year when they put the new potential offerings.
But here, the only thing that I want to say in terms of upcoming grant opportunities, and there might not be grant opportunities on the federal level, but one of the things that I think states are looking at relative to the implementation of the Affordable Care Act is if there are state or block grant appropriations that are now being utilized to fund treatment services that will now be covered when clients, when people get insurance, are there opportunities on the state level to redeploy those dollars in ways that are not currently reimbursable? So, there might be an opportunity, and again, I know that many states are pressed without having enough resources in general, but is there an opportunity at the state level to redeploy those dollars for other services that are not or will not be reimbursable by other payers? So there might be some opportunity to free up some of those dollars in thinking about pilot programs. Specifically related to DWI offenders in jail settings. And again, I don't think that there's, to our knowledge, been specific projects that have focused on screening and brief intervention opportunities with DWI offenders. But, clearly there seems to be a need for looking at how you might do that. I know in many parts of the grant requirements, whether it's not necessarily just screening and intervention, that many state agencies and many providers are looking at motivational interviewing techniques relative to moving people along the stages of change. So there are, I think, opportunities to think about whether it's working with DWI providers or other jail settings to think about not just screening and brief intervention, but looking at things like motivational interviewing to change behavior. Oh, please repeat the website that you just mentioned. It is www.mass.gov/BSAS, B-S-A-S. And you should. Last time I checked, I think there's a drop down or on the homepage. There's training resources, and I believe that curriculum is still on the site. If it's not on the site, I'll work with Joe and folks here to make sure that we get you a link to that. There's another question about Illinois is due screening in community courts, and that came from Danny Kirby. So she's a program director for the Illinois SBIRT project. So she would be a good person to follow up with, as well as misdemeanor courts. So there actually are grantees who are focusing on that population. So
yes, but not specifically in jails or.
But not in jail. So this is the front end kind of court setting, which is good. So that's the last question that we have. I want to again thank JBS for the opportunity, SAMHSA and JBS for the opportunity to do this, and thank you for your participation today. And Tanya was nice enough to put the link on the chat blog, so it should be there available for everybody. Oh, it says indicates page not found. We'll get you the right link. Thank you. Thank you, everybody.